won't work. We have to have volume in that SVC, IVC area in order to pull blood from. Otherwise, it collapses and we just can't generate the flow. VA ECMO, many times it can become non-pulsatile or decrease pulsatility because the return flow is obscuring the natural pulsatility of the heart. Plus, many of these hearts are already compromised. They're not getting good squeeze anyway. And this can have a little bit of some complications down the road. Pulsatility is ideal for end organ perfusion. So you'll see a decreased arterial waveform. So what we do to make sure that we're supporting patients in a circulatory fashion is follow MAPS. We don't look at systolic, diastolic most of the time. You have to look for LV distension. You're returning the blood back to basically the aorta retrograde. So the native heart is trying to pump against flow that you're pumping the opposite direction. So we have to watch and make sure that our LV doesn't become too overworked, especially in those cases where the aortic valve isn't very compliant. And so sometimes we have to put in what's called an LV vent, which is another drain line to keep that LV from distending. And we'll minimize the afterload using milrinone or nipride as well. And then adequacy of support, we look at urine output because if you're perfusing the kidneys, you're usually perfusing the rest of the body. Your venous oxygenation, which is one number that we follow pretty closely, your acid-base status and lactate. SvO2 and lactate are usually kind of our gold standard for whether or not we're perfusing the body adequately, circulatory and with oxygen. And then you'll look at your serum creatinine and LFTs to make sure you're perfusing the kidneys and liver. And here's an example of VA cannulation. So it usually for adults will cannulate in the groin, in the femoral vein, and return here into the femoral artery. Once again, we're pointing retrograde back up the femoral artery, so that's where you get some concern about afterload on the left side of the heart. Here's an example of VA in our neonates. You're cannulated in the superior vena cava. Tip generally rests in the right atrium, and then we're returning in the right common carotid. That's why many times you'll have to see them, the carotid ends up getting ligated. It's okay, they got two. And you'll get your retrograde flow going down that carotid artery. And then central cannulation. Like I said, sometimes with our cardiac patients coming back from cardiac surgery, you'll cannulate directly in the right atrium and return directly into the ascending aorta. So what's this all about? Well, if we didn't have an oxygenator, it would just essentially be a VAD, ventricular assist device, or a pump. Because we have an oxygenator, we're including an artificial lung, and so most of this is all about oxygen. Oxygen content, oxygen delivery, and oxygen consumption. That's what we're concerning ourselves with the entire time. How are we getting oxygen into the blood if the lungs aren't working that well? How are we delivering oxygen to the tissues if the lungs and or heart aren't functioning properly? And then how much oxygen is the patient consuming? So this great picture from like 1970 shows us that basically the difference between those concepts. Arterial content is determined by the oxygen that we breathe into our lungs and then the amount of hemoglobin. We all know that 96% of the oxygen that's delivered to the tissues in a normal person is bound to hemoglobin. So we need to have both of those components. We need to have adequate red blood cells, and we need to have our lungs functioning properly. And then the delivery, it then throws in the flow, and that's determined by, in your native heart, by our cardiac output. So you put all those together and you get your oxygen delivery to the tissues. This is supposed to be kind of like a power plant, I guess. I don't know. But basically it shows at the tissue level what's happening is this is where your oxygen is consumed. And so standard metabolic rate, what you're doing at rest. Sometimes you'll throw in sepsis or injury, or if you're exercising, that increases the consumption. And then what comes back is our venous O2 content. And this is how we're determining whether or not we're supporting our tissues adequately with oxygen. We're looking at our venous O2 content, and the AV difference is what we want to look at. I'm sorry, this slide is really blurry. I tried to find a clearer one. Not a whole lot. It's basically the same picture, but the thing I want you to look at down here is the ratio. Delivered oxygen 600 and consumed oxygen 120. That's basically a standard metabolic situation at rest. When you're in a normal condition, the human body is at basically a 5-to-1 ratio. We deliver 5 times the amount of oxygen that we consume. And what's returned in venous is our oxygen reserve. This slide just basically shows your O2 content and how hemoglobin can dramatically increase it. So one of the things that we consider is not just how well the lungs are working and how much oxygen we're putting into the blood, but how much carrying capacity we can have. Since we're not in hyperbarics, we're under a normal condition, most of our oxygen is bound to hemoglobin, and if you're having trouble getting oxygen to the tissues, sometimes increasing hemoglobin can dramatically increase the amount of oxygen you're delivering. And from a hemoglobin of 7.5 all the way up to 15, it's more than a double-fold increase. This slide basically shows our differentiation between oxygen delivery down here and oxygen consumption. And as you notice up on this is kind of the normal plane, or the normal line, slope of the line. And as here at rest, as you do things to the body, operation, fractures, sepsis, all the way up to light exercise, your oxygen delivery has to dramatically increase with your oxygen consumption in order to maintain that homeostasis. And then if we look at this model, that's essentially that same line as the normal line right there. If the oxygen delivery isn't able to keep up with the oxygen consumption over here, you start to lose that ratio. So right here, we're at probably about a venous saturation of about 80% in your normal condition. But if we can't keep up, you're going to drop down to 4-to-1 ratio, 75%, 66%, 3-to-1, 50%, 2-to-1. We're getting down in these ranges, we're at an oxygen deficit. And that's kind of where your anaerobic respiration, your lactic acidosis starts to occur. And then just another way to interpret that diagram, your normal situation is sitting right here. Kind of superimpose those other lines on top of here. As you get down into that 4-to-1, 3-to-1, 2-to-1, you're dipping into your oxygen reserves. And once you get past 2-to-1, you kind of get into a shock condition. And this is where you start not meeting the metabolic demand of the tissues. Your critical low point here is at the ratio of 2-to-1. Your venous oxygen saturation is going to be hovering right around 50%, and that's when you start to run into problems. Because we start to get into ischemia and things like that. So what do we do on gas exchange, and how does it differentiate from normal lung? Well, in oxygen delivery in the normal lung, it's determined by what we discussed before. Hemoglobin, how much oxygen you're attaching to the hemoglobin, and then cardiac output. And then CO2 removal is roughly congruent to that, but that's provided if you're on a ventilator, as you all know. Volume and respiratory rate, that gives you your minute ventilation. That's how you clear CO2. In the membrane lung, it's a similar situation. Everything is determined by flow. Flow determines oxygen delivery. If you're assuming that the blood coming out the back of the oxygenator is 100% saturated, which is a PO2 of about 90 to 100, then the flow of the pump is what's going to determine your oxygen content or your oxygen delivery. And so that's what we're going to basically look at here. And same thing for CO2. The clearance of CO2 is going to be determined by your sweep gas. Sweep gas is the similar or same to minute ventilation on a ventilator. Everything's determined by flow. Well, you'll hear us talking about it all the time. Go up on flow, go down on flow. But the more flow that we have available to us, the better. So CO2, once again, these concepts are what we're going to live by all the time. Since many of these patients have injured lungs, our gas exchange is no longer going to be determined by the ventilator. We'll discuss what the ventilator's purpose is. But now that we have an artificial lung, all gas exchange is determined by the artificial lung. And so clearing CO2 is going to be a purview of the sweep gas. We'll go up on the sweep flow to clear more CO2, down to clear less. And then our oxygenation is determined by pump flow. Going up on the pump flow increases oxygen delivery, going down on it decreases oxygen delivery. In VV, it essentially changes the content. Once again, we don't provide any cardiac output on VV ECMO. So we can't do anything about delivering it to the tissues, but we can increase the oxygen content that's on the right side of the heart. Indications. I want to highlight this word that I put in red. It's clearly important, right? Going to be on the test. These patients have to have a reversible condition. We're going to be looking at patients that are going to be bridge to recovery, or bridge to transplant, or bridge to an alternative device, or in some cases bridge to a decision. We've put the patient on ECMO, we've given them a chance to maybe recover. They're in a non-recoverable position, so we're giving the family a chance to decide what to do at that point. But we have to have a plan. ECMO is a bridge. It's not a treatment. It's not going to fix the heart. It's not going to fix the lungs. What we're doing is we're in supportive therapy. We're going to support the heart and lungs until they either recover on their own or we move on to something else. So what are some of the indications? Hypoxic respiratory failure. And so these numbers really don't mean a whole lot to us. I mean, they do. I'm a numbers guy, but you're going to basically be able to tell when your patient may be requiring ECMO. Some of these things that we look at: PaO2 FiO2 ratio, oxygenation index, Murray score, which is something that takes, severity of lung injury, chest X-ray, oxygenation index, all of that into one. One of the ones that was just easy for us to look at, if your patient's on an FiO2 of greater than 90% and a PEEP of greater than or equal to 15, they're kind of heading down that road. We're not able to, for whatever reason, adequately support them with their oxygenation on these settings. Then you might want to start considering that. And in our medical ICU, we do a lot of proning and paralyzing of patients in hypoxic respiratory failure. If you're considering doing this, you also need to be considering this, because proning and paralyzing is basically the last step before they finally fail. So for those of you out there, working, if you're seeing some of these factors, maybe you should be talking to your physician a little bit about, hey, maybe we need to contact ECMO or contact an ECMO center. CO2 retention due to asthma. This is a great indication for ECMO. The reason being is there's not really necessarily an underlying lung injury. It's usually asthma exacerbation, your bronchial constriction. So what we'll do is we'll throw them on ECMO. We'll clear their CO2 for a few days, allow that smooth muscle to relax, and then we can take them off. It usually only takes 2 or 3 days of ECMO before that asthma exacerbation clears up. PaCO2 greater than 80, and you just can't achieve safe inflation pressures or able to ventilate the patient adequately. So good indication for ECMO. And then severe air leak syndrome. If you have a patient that is on high pressures and you're popping a lot of pneumos, let's put them on ECMO and see if we can maybe get those lungs to heal. And then some of the cardiac ones, serious systemic hypotension. So we're not able to maintain blood pressure. Even with maximal inotrope therapy, we'll put them on ECMO and see if that'll recover. Acute hypoxemia, that's cardiac related, so the right-sided heart failure. You're not able to pump the blood through the right side of the heart and the lungs. And then all the cardiogenic shock indicators: hypotension, low cardiac output. In the adults, if we have them on a balloon pump, myocardial stun, all of those are things we should be thinking about ECMO with. And then bridge to transplant or other assistive device. We do many times initially put them on ECMO, but then we see that their heart just isn't going to recover. We can transition them then to a VAD device, and that's either a destination VAD where they're going home with it, or a VAD that's a bridge to a transplant. Pediatric indications, roughly the same. Your surgical population, sometimes we do need to stabilize them before they go to the OR. Their cardiac dysfunction is so severe that they just can't sustain themselves before they go to the OR and get a repair. Failure to wean from bypass, sometimes they come back from the OR on ECMO. And a lot of times that has to do with just bypass time. They've been on bypass for a long time and their heart needs a chance to recover. And then low cardiac output. Despite maybe surgical intervention, the heart just isn't able to function. And so then we'll think about some other things down the road with those patients. Non-surgical ECPR, this is becoming more and more common. A lot of larger centers are utilizing ECMO as an adjunct to CPR. You're providing CPR or ACLS to a patient. After 10 minutes, you're not able to achieve ROSC. We can percutaneously at the bedside throw in a couple of cannulas, throw them on an ECMO pump and stabilize them, and then see what the problem is. And they're finding some really good outcomes if you have a system set up that can handle that. Myocarditis, cardiomyopathy, respiratory illness, once again, VV is a great option, and pulmonary hemorrhage. It used to be in the past, those of you that have had experience with ECMO in the past, bleeding complications or pulmonary hemorrhage were a problem because we heparinized all of these patients due to the complexity of the circuit. Well, we can run ECMO without heparin now. We don't want to do it forever. We can't do it forever. But pulmonary hemorrhage is now not a